What we do here matters, because what we don't do matters even more.
We need to continue to push, and we at ADAO are going to continue to push the Surgeon General of the United States.
As you know, the United States continues to use asbestos, and that indeed is a barrier to others stopping its use.
The most horrific part of this whole story is that it is preventable.
Thank you, Dick. Well, I've been asked by Linda to come talk and catch everybody up on Libby. Well, I'm sure there are a number of people in the audience that probably don't know everything about Libby, so I'm going to have to backtrack just a little bit and then talk about what we are doing right now. We have some active research going on and some preliminary evidence. We're not completed with our projects, but do have some preliminary data that is quite, stands out and does give us some interest to look farther. So I do want to go back a little bit, and the next slide is, where am I here? So, what do I do here? Huh.
You didn't get the training course?
No. What are you doing there? Now, how do I go back? Now I go back. There. We do have to go back a little bit, and I bring up our good friend Steve Levan, of course, who we cannot talk about what we do in Libby without talking about Steve. And Steve was there with us early on in the 2000s, looking at our lung disease and trying to help us figure things out, figure out how to study it. And unfortunately, we lost him along the way, but we did share some very good times together. And I think I showed you this picture once before. But along with the fun, Steve and I spent a lot of time looking into the cases. And Steve coined this little phrase, I know this is not your grandfather's asbestosis here in Libby. You'll note up here the key features that he saw right away were, hey, your plaques, they don't just sit there, they progress, and sometimes quite rapidly. And so and then the progression was in the form of a very diffuse pleural process, and there was very little interstitial disease, even in the most highly exposed zone-light workers. And of course, this is just a quick picture of the very thin, nice thin layer that's called the pleura that goes around the lung, and it's smooth. You can look right through it and see the lung tissue. And of course, this is a thoracoscopy look at the inside of one of our chests of people with disease. You can see this thin layer of white fibrous material that smoothly layers the chest, inside the chest surfaces. And this is what we typically see, not the really prominent plaques. And so we had this atypical pattern with rapid progression. When I say that, people went from good function to severe disease and death within 6 to 8 years. Usually this was associated with very severe chest pain, very severe pleural pain, had to be treated with narcotics frequently. It was so severe and unrelenting. And this is how fiery red the pleural surfaces looked when we did thoracoscopy. You can see just how intensely red they are. This is not what they're supposed to look like. And once again, back on that, Steve said he'd never seen the inside of a chest look like that in his population of steam fitters and insulators at Mount Sinai. And then if you go back and say, what does ATS say about chest pain? Well, you'll see it's, gosh, it's such a rare condition. Chronic severe pleuritic pain is rare in patients with asbestos-related disease. There's been some studies out of Australia and of course, the crystallite exposure, and there are some articles on chest pain out of the groups there, but none describe this pain with a severe nature to it. Reminder of the size of our cohort in Libby, we've had more than 80,000 people exposed during the life of our mine. Currently, we've seen over 5,000 individuals, and of those, about over 2,000 have had evidence of asbestos-related disease. And we are, the rate of cases showing up each year is approximately 500. We have not seen, we have not hit the peak. And then just some NIOSH data to remind everybody that, yeah, Lincoln County, Montana, where Libby resides, is still carries the highest age-adjusted death rate for asbestosis in the country. So anyway, here's the projects. Steve spent a lot of time thinking after he'd looked at a lot of cases in Libby, and he and I sat down together and thought, well, how should we tackle this thing? There's so much to look at. How are we going to define, get a better idea of how this disease relates to what we've traditionally seen in asbestos disease? So we started looking at the different opportunities, and one of those was to look at childhood exposures. And so we thought, well, we'll design a study that where we'd look at people that lived in the community but left the community about the time their lungs had fully developed, and then didn't get exposed to asbestos once they left the community. We'd like to know what happens to those individuals getting exposed to Libby amphibole during the times of their lung development, and did that create worse disease down the road for them? Secondly, with recognition of the severe pain and rapid progression of the disease, we also wanted to compare our populations, the Mount Sinai, the steam fitters and insulators at Mount Sinai. We wanted to compare the rate of progression of their disease with the rate of progression in our Libby amphibole exposed population. So we had a CT progression study that we laid out. And then thirdly, there was significant interest in non-pulmonary health effects, specifically autoimmune type phenomenon. And there were certainly early indicators that there could be some relationship there. And then we also, in this process, had to come up with some sort of a methodology to understand exposure in our population to relate to the diseases that we were going to be measuring. So anyway, this was the first project. I don't want to belabor that because we're still in process with this. It's very hard to track down people that left a community at age 20 or 22 and then try to find them is very, very difficult. But we've managed to, with our staff, hunt down these characters that played in the piles, and had a great childhood, and then left and went on to other things. And you can see that we pretty much cut the age off for men at 22 and for women at 20, and so they really had to be exposed prior to that time, and then in Libby, and then if they left the community, they could not be exposed or not have a history of being exposed to asbestos outside. And currently we have 130 subjects enrolled, and I think that's bumped up a little bit, hasn't it, from there? So, and we hope to get a number more through the summer. And then this is the CT scan progression study where we've developed a methodology for scoring CT studies, and we've done some early validation of that methodology that Steve and I'd worked on, and so we are in the process of this year we'll be taking the second scan. We'll have scans that are at least 3 years apart. We'll be looking for progression and comparing that between the Mount Sinai population and the Libby amphibole population. And anyway, our hypothesis is that the lower environmentally exposed Libby amphibole population we think is going to have a faster progression rate on the CT study than the progression in the asbestos workers in the Mount Sinai cohort. And here's what we saw right away when we started looking at cases. This is a typical Mount Sinai case, and do I have anything on this? Well, anyway, there's a pointer. Yeah, see the large plaques that stick out into the lung. The lung's black, and then you can see these large, irregular white areas sticking out, which are plaques. These are just well-identified circumscribed plaques. And this is the more typical pattern seen in the Mount Sinai population. The pleural reaction tends to look more like this. And then if you go to the Libby population and look at a Libby worker, this is a zonalite worker, and you can see there's just a thin layer that surrounds the outside of the lung and lays against the rib. And it's a very, I don't know how many you can see that, but anyway, there's a thin layer in there, and that's the typical pattern. Libby's disease does not get thick. It leaves that, I showed you on the one picture how thin that layer is, but it becomes more fibrous and dense over time, but does not thicken to any great degree. So it's frequently easily missed or misidentified even in the B reading process. And that's a little bit more about the CD scanning. I think I want to move on because right now this is in process. We have no data. We have not done our second score. You know, we're not into the scoring far enough to have any data right now, but will next year most likely. So anyway, the third area of interest was his autoimmune outcome study, and we wanted to explore this relationship between the exposure to Libby amphibole and the development of autoimmune diseases, and also the possibilities of some relationship to the severity of the asbestos-related disease. And so we were hypothesizing that maybe several things were going on with this exposure, and that brought the question, and you see, could the characteristics of rapid progression and intense pleuritis be related to an autoimmune mechanism? This was just not, this is so atypical, we had to start thinking outside and saying there must be other mechanisms involved in this disease. And so anyway, in the outcome on the autoimmune, we noted that there's no increase in the anti-CCP, in other words, more specifically looking at the development of rheumatoid arthritis. We didn't see any increased level of those types of antibodies. However, what's interesting, and you'll see over here, is the, oh no, I didn't do that, did I? Okay. There we go. You'll see right here, we detect it. You'll see in the cross-trial exposed group, less than 1% were showing up with these autoantibodies. And this is just a general ANA panel screening. Whereas in the Libby amphibole group, we're seeing levels that are 62% of the individuals were showing up with these autoantibodies. More like silica, a more typical pattern for silica. And along with this, we noted this, the cytokine IL-17 increased significantly and compared to the Sinai population. And when you see the Missoula cohort is a non-exposed population that's continued to be used as one of our comparative cohorts. Then we started looking more specifically at autoantibodies against cells, and we looked at mesothelial cell autoantibodies and tried to see what correlation we might find with that. And it turns out in the populations of Libby and Mount Sinai that it's about equal. About 19% of the sera show these mesothelial cell autoantibodies. But they definitely are significantly elevated in those cohorts compared to the Missoula cohort of the non-exposed. But what's interesting and different is that in the Libby cohort, the presence of these antibodies correlated well with the pleural disease, as opposed to the Sinai cohort, where it didn't seem to matter. And I'll show you some. Oh, okay, I'll show you this Venn diagram because this shows it well. In the Libby amphibole screen population right here, you'll see the antibodies. The intersection is high. There's a high correlation of the presence of these mesothelial cell autoantibodies with the development of pleural thickening. Now, if you go to the Sinai group, you'll see these antibodies don't intersect that well. So this is a real question, that we're trying to dig through right now, is why these autoantibodies don't seem to have any influence on the pleural thickening in that population. Now there's, we can project that something in this, the MCAAs and the Libby amphibole population have something to do with rapid progression and some of the other aspects of the clinical manifestations we had been seeing. And certainly we didn't have any real understanding of the mechanism of the action. It was proposed ultimately that maybe it has something to do with collagen deposition. And so looking at that, we found, well, no, it really, whether the autoantibodies were in those of the sera of the Libby amphibious population or the Mount Sinai population, they both seem to generate collagen synthesis in the cultured situation. But they, I'm trying, okay, I got the, I don't know if I, these are slides that I actually borrowed on this one. I'm trying to remember, okay. Yeah, and so ultimately then the point would be is the increased collagen, if it's occurring but it's not from increased synthesis, you see above it, it does not increase synthesis, but it increased the presence of collagen. So and somehow it's thought that it may, the autoantibodies may have some influence in the turnover of the collagen, therefore the collagen builds up because it doesn't have the controlling mechanisms there to reduce the load of the collagen. And so, and we're still in the study of trying to understand that more. I just want to mention, I'm done here. Anyway, we are screening for lung cancer. We do have a high-risk population, as it was talked about earlier. And so we actually, we're very lucky. We have a screening program that allows us to do that. And so just wanted to let everybody know that's going on at CARD, and I'm done. So.
Thank you, Dr.